Well, thank you very much indeed for the invitation to speak. It's always an enormous pleasure and really quite exciting actually to do these presentations. And the title is really a very, very simple one. It was Genetics and ADPKD, Polycystic Kidney Disease. And what I've tried to do is largely to base the content of this sort of brief overview is based on what are the commonest questions that I tend to get during my own kidney genetics clinic. For the last nearly 30 years or so, I've been doing a regular kidney genetics clinic. The vast majority of people who attend the clinic or that I have contact with have a diagnosis of ADPKD, as I'm sure you're aware. So what I really want to cover very, very briefly is, what do we mean by genetics? That's a common question. People mean, well, why am I seeing a geneticist? What do you mean by my genetics? What do we mean by genetic testing? And why might I be offered genetic testing? And the opposite is, I've never been offered genetic testing before. Why am I being offered genetic testing now? And the rather interesting issue around what do the results actually mean? And that's a very interesting area currently with delivering genetics more broadly through the NHS is interpreting results to anybody who happens to receive them, whether it's a medical professional or an individual or family member. And of course, do you have to have genetic testing? It's not uncommon in my experience at the moment, not just in kidney genetics, but in my general genetics clinical practice, for people to decline genetic testing. And of course, what should you tell your family, in particular the result? And the final one, which has been something I've been asked much more in recent months and years, is, can I test my children? So I'm going to try and go through those fairly quickly, but be very, very mindful of time. So genetics or genomics. So I think we've all become very, very familiar with DNA testing at home. I'm not going to mention any of the big name companies that do this, but it would not be unusual for me to chat to somebody to say, you know, I've thought about doing a DNA test at home. What's that going to tell me about polycystic kidney disease? Well, in very general terms, we can all access that type of testing. That's genomic testing, because it's looking at all parts of your genetic makeup in one sense or another. Genetic testing tends to be much more focused on a particular gene, and in the context of polycystic kidney disease, it's the PKD1 or PKD2 gene, or some of the other rarer genes that we've already spoken about. That has very clear medical implications. This type of home testing or genomic testing, especially when it's done outside of a research project, for example, is much more likely to be offered to think about ancestry, lifestyle decisions, possibly family relationships. And we've heard lots of stories about how that can identify new relationships. Sometimes it's carrier testing for specific conditions like cystic fibrosis, when a single genetic alteration is very common in a population, for example. We're aware that more direct-to-consumer testing, if you like, tests are being made available, for example, in the context of early pregnancy screening, and more recently tests becoming available for what's called disease risk prediction. And that's not necessarily diseases that have a strong genetic basis, but that would be diseases that very often are much more common in the general population, but don't have a strong genetic basis. The ones that are certainly being marketed at the moment, you may have heard on the news recently, is prostate cancer, for example. So we're not talking about this type of home DNA testing. We're talking about really the medical application of a genetic test for a single condition. And another interesting point that's frequently brought up is the disease ADPKD. We're very often asked, what does the A mean? I thought it meant adult, and a lot of medics still think that this means adult. No, it doesn't. It means autosomal. And what does autosomal mean? Well, if we think about all of our chromosomes, for example, we have 46 chromosomes in 23 pairs, and one of each pair is inherited from each parent. That's why we're 50% mum, 50% dad. And the chromosome pairs 1 to 22 are called the autosomes. And that distinguishes them from the X and the Y chromosome, which are the sex chromosomes. And it just so happens that PKD1 and PKD2 genes are on the autosome. So that's the term autosomal, if you're not aware of that. And that clearly implies that as an autosomal condition, it can affect men and women equally. What about the dominant bit? Well, I think probably most people, and certainly in my experience, most people do have a very, very good grasp of what dominant means. It essentially means at a very practical level that this is a condition that can be passed from generation to generation. And at a sort of a genetic level, if you like, because we have 2 copies of every single chromosome and then every single gene, only one altered copy of the gene is required to cause the condition. The other copy, inherited from a healthy parent, for example, is completely normal, and that's not able to compensate or prevent the disease occurring. And of course, as a dominant condition, there then is a 1 in 2 chance of passing on the altered copy of a gene to a child, for example, and it's the same risk for each child. So that explains dominant, and that therefore tells us about why the condition is called autosomal dominant polycystic kidney disease. That's the very, very basic part of our genetic understanding of this particular condition. I've mentioned that there, and I'm sure you've heard in previous talks, that there are 2 main genes for polycystic kidney disease, PKD1 and PKD2. We are becoming increasingly aware that there are a small number at the moment, about 3 other genes that account for a very tiny proportion of cases, but we are getting much better information about that. But essentially, PKD1 accounts for about 85% of individuals and families with polycystic kidney disease. And we've known about that gene for a long period of time. That's on chromosome 16, and PKD2 accounts for the remaining 15% of cases, and that's found on chromosome 4. So our knowledge of the basic genetic architecture or basis of disease has been known for quite some time. And so that clearly starts to tell us what we mean by genetic testing. We're talking about looking at a particular gene that we know is very, very strongly associated with a particular condition. And in the respect of polycystic kidney disease, genetic alterations in PKD1 and PKD2 really are not responsible for any other human health conditions. So testing of those genes is essentially a test for ADPKD. And testing in the clinical situation that we're more used to it is going to be using a DNA sample that's isolated from either blood or more recently, we've also been able to use saliva samples as well. And that's actually very, very helpful. If somebody, for example, the test is being arranged outside of a clinic, for example, and they can then post in a saliva sample. And saliva has also been very, very useful for children. So that's really quite a good, significant advance. And a saliva sample is very different from a buccal sample where you're scraping the inside of a cheek. A saliva sample literally means, I'm afraid to say, spitting in a tube, but the DNA quality is very, very good. And what we can say about that is that when we look at the previous diagram describing a chromosome is really just the storage, the visible storage system for DNA. So if you unravel a chromosome, you get to this so-called DNA helix, and that DNA helix is made up of these so-called base pairs, A, C, G, and T. And when we're doing a genetic test, it's that bit in the majority of tests where we're sequencing DNA, it's that string of bases, the code A, C, G, and T in every position that we're trying to determine. We're not looking at counting the number of chromosomes or whether the chromosomes appear normal in themselves, although that is a very common type of genetic test. For genetic testing in a condition such as polycystic kidney disease, we're looking at unraveling the actual DNA code. And just to take that into a little bit more detail, especially for those people who may already have some understanding of genetics, but for those of you who don't, this I hope will be very helpful. When we're looking at our total amount of DNA, it's split into lots of different components, but 2 bits in particular are important. For genes such as PKD1, they're made up of parts called exons and parts called introns. The exons contain, in a sense, the important part of our genetic information, as it's those information, as it's those parts, the exons and the genetic information in them, that when the DNA is used as a template to make RNA, those exons are in a sense stitched together, and that RNA forms a template or an instruction to then go on and form the protein. And the vast majority of disease-associated genetic alterations are found in the exons, the so-called coding parts of our genome or genetic makeup. And it's that where we predominantly look for genetic alterations responsible for disease. And so when we're thinking about that, another question that I'm often posed with, well, why does it take so long to get a genetic test result? Well, it's not like a measurement of a creatinine test where, whilst it might be technically quite challenging to do that, the turnaround time is literally minutes or hours. In terms of a genetic test, there's a whole complex workflow, and that workflow is constantly being updated by new technologies and new methods of computational analysis of the data that those so-called sequencing technologies produce. So in this particular schematic, which comes from America, they show DNA extracted from liver. Well, we rarely, if ever, do that. This is DNA extracted from blood or saliva. But we have very robust methods to extract DNA. That takes up to a number of days to make sure that the quality of DNA is good. We can then go on using a number of different techniques to look at the PKD1 and PKD2 genes, and I'll come on to how we might do that. But essentially that's run through a variety of different so-called sequencing platforms that have a variety of different stages in those that more recently have become more and more complex, but more and more high throughput, such that we can put those DNA samples onto very, very new high-tech sequencing machines called next generation sequences. And that generates huge amounts of information. And it's the analysis and interpretation of that information that often leads to the length of time taken for a genetic test result to become available. We have an average reporting time here in Cambridge, but across the country, I think the recommended reporting time is up to about 18 weeks. So it can appear that it takes quite a long time. If required, we can occasionally produce a result or a report in anywhere between 1 to 3 weeks. That's the exception, though. So thinking about that in a little bit more detail, I've mentioned that there are potentially a number of different platforms for how we can generate a genetic test for you. We can look at each gene in isolation, and we've had methods to do that for many, many years. So really from the DNA sample, we're just looking at PKD1 and PKD2. More typically now, we would look at PKD1 and PKD2 in the context of a gene panel where we might be studying 5, 10, 20 or 30 genes. And as John and his team have previously mentioned, ADPKD is part of a ciliopathy. There are many, many ciliopathies, and we now run ciliopathy gene panels, which include PKD1 and PKD2, and they can include tens, if not hundreds, of genes, so an increasing order of complexity. We also carry out exome sequencing. I've explained to you what an exon is. It's a bit of a gene. There are 20,000 genes, and we're now able to analyze all of those genes and all of their exomes at the same time. And from that, we can then extract the data on PKD1 and PKD2. But now we have whole genome sequencing where we just sequence the lot, not just the exomes, but it's the exons, but the exons and the introns and everything else. But again, from that, we extract the information about PKD1 and PKD2. So we're filtering. I always like to think of whole genome sequencing as sequencing the Encyclopedia Britannica, but we know which volume and which page the PKD1 and PKD2 genes are on, so we can go straight there and look straight away. And you can imagine not many years ago, the cost, complexity, and analytical time of doing that was absolutely huge. Now, the cost, complexity, and analytical time has changed so substantially that actually we are not far off perhaps having the most cost-effective and rapid way of delivering a genetic test for PKD1 and PKD2 may well be whole genome sequencing. That's the sort of target that we're aiming for. And again, that has the the potential of delivering results in days and weeks rather than months as well. And we should be able to see that clinically in the not too distant future. And that's largely been driven by a number of different worldwide projects, but not least of which a really fundamental driver of change in offering genetic testing and genomic testing in the NHS, the 100,000 Genomes Project. And some of you, I hope some of you at least, would have been able to have taken part in that project and will have either received your results or be receiving your results shortly. And that is, as I've already said, that is delivering clinical genetic testing for polycystic kidney disease, but using whole genome sequencing as the platform to do that. So that's going to have a very, very profound impact on how we deliver genetic testing across the NHS in the near, medium, and distant future. So there's lots of innovations and change that are just about to happen. And we've been waiting a little while since this particular project finished, but we widely anticipate whole genome sequencing becoming available within the NHS within the next few weeks or months, and you'll hear a lot about its launch. So thinking a little bit more about genetic testing, I've mentioned what we're doing. We're looking at DNA code in the PKD1 or PKD2 genes, and that's a string of bases, as I've already explained, A, T, C, or G, and they can be sequenced in an individual and compared to what we consider to be, if you like, a normal version of those particular genes. And having that sequence then allows us to predict what that gene would encode, the protein sequence of the PKD1 and PKD2 genes, which are often referred to as polycystin 1 or polycystin 2. So we can go from DNA sequence to predicted protein sequence very, very easily. When we do genetic testing, we're looking to see how an individual's DNA sequence varies away from normal. And sometimes the genetic alterations are very clear for us to pick up. They can be so-called nonsense mutations, and essentially that means that the DNA sequence no longer codes for a complete protein. So that protein stops, and we would widely expect that protein to no longer work, something that we might call a loss of function mutation or alteration. There may be just a single change in the DNA sequence which gives rise to an altered amino acid, part of the protein sequence. You can see how the amino acid here is different. That we often call a missense mutation, often referred to as a spelling mistake, if you like. That may not lead to a loss of function of the gene, it may lead to an altered function, but we're aware that all of those types of mutation, for whatever the underlying mechanism is that you've heard previously this morning, can go on to cause the clinical condition that we call autosomal dominant polycystic kidney disease. But there are other types of genetic alteration that we are aware of. So here's the normal DNA sequence, here's the normal protein. These are just schematics or cartoons, for if you like. We know that sometimes a bit of the DNA sequence is missing. That is often called a deletion. Some of the DNA sequence may be copied. That can be called duplication. A new bit of DNA sequence or a base, if you like, can be inserted. That can be called an insertion. And they all lead to predicted alterations in the protein and hence protein function. And all of these are types of the genetic alteration that we are now detecting by genetic alteration. And this type of information will be reported on your genetic test result. So we've had over 10 years of delivering genetic testing for polycystic kidney disease in the NHS. This was initially run by an organisation called the UK Genetic Testing Network, and it's been widely approved and available to all centres in the UK. It's now being delivered via what's called the genetic genomic medicine service, which is covering a lot of the newer aspects of this in the NHS, and testing for PKD1 and PKD2 and other PKD genes is now fully detailed within something called the test directory, which we're all allowed to follow. And ordering tests for polycystic kidney disease are now available to both kidney specialists, nephrologists, and geneticists. We've heard a little bit about the PKD1 and PKD2 genes in previous talks. And as John previously mentioned, the PKD1 gene is much larger and more complex than the PKD2 gene, which is more relevant. But these simply represent the number of exons for each individual gene that we look at. And because certainly of the size of the PKD1 gene, it's not always easy to spot or find or interpret and hence report what the underlying genetic alteration is that we believe is causing this condition in each individual family. So it is not always straightforward. So when we come to thinking about what results mean, the report can seem a little bit baffling. And I think many centres, including our own here, are now starting to do a lot of work about how these reports can be improved very, very substantially to communicate the information to individuals, their families, and also clinicians looking after them to make them more easily understood. So a current report may say this sort of information. It will tell you a little bit about the gene. It will give you the coordinates in the gene where the genetic alteration has actually occurred. So this really is a sort of, if you like, a page number or a word number telling what's going on. It'll tell us it's a deletion. It will tell us there's a T missing. And then it'll tell us what effect that's had on the protein sequence. This is what P stands for. C stands for coding sequence. And what that tells us is that by removing this one single base, it basically scrambles the protein sequence. It's called a frame shift, and it is very, very likely to lead to protein that's significantly altered and is non-functional. So this makes it, this type of mutation is more easy for us to interpret. And so we would call that pathogenic, i.e. that's causing the disease. And we would often make an additional statement here to say that this particular variant has not been seen previously in a variety of different genetic databases, for example. That in a sense is something that we see quite often in polycystic kidney disease, that genetic alterations are unique to individuals and families, which also makes their interpretation slightly more problematic in some cases. But this is really just our own housekeeping report, if you like, to say what we've done to interpret the significance of these variants. And the report may well then say that test confirms a diagnosis, but it will also depend on the context or the reason for the test being performed. And it then may well make a statement to say, well, testing is also available for other family members or for the other known indications for testing for polycystic kidney disease. However, there are other test outcomes. We may say that something is lightly pathogenic. So this means that there isn't the evidence to say that it is definitely causative of the condition, but it may well be that additional evidence will allow us to determine that it is pathogenic, for example, by testing other affected or other unaffected family members to see whether they carry the same variant. We may find a variant of unknown significance. This is not unusual in polycystic kidney disease, because certainly in PKD1, it's a big gene. There's a lot of normal natural variation in that gene. That just makes us normal human, individuals who, and it explains potentially why lots of us are clearly different from each other, but we don't understand what that normal variation means. But what it does mean is that that variant of unknown significance, it may not have been seen anywhere else at all, but we don't have the ability to say with any level of certainty that that variant causes disease, and we will generally have to wait until more evidence becomes available. And possibly about 5 to 10% of people who've clearly got polycystic kidney disease, we cannot identify the underlying causative genetic alteration using the tests that we currently have. But it may well be that in the future, whole genome sequencing will mean that that number of individuals will reduce to a much, much lower level. So we'll wait and see. So what are the reasons that genetic testing may be considered? And I think it's most people's experience, certainly the people I see in my clinic, they come to us, and the majority of people will have already received a diagnosis or know of their family history simply because of imaging studies using ultrasound, CT or MRI. Still remains the most appropriate diagnostic and screening investigation for this condition. However, genetic testing, because of its availability, because of our knowledge about how to deliver and use genetic testing in our clinics, we also know that it can be used very, very effectively in what we call diagnostic testing. A lot of the time that's being carried out in children and infants, for example, who may have been found to have kidney cysts, or adults who've been found to have kidney cysts. They may not have enough cysts to make a diagnosis, or those cysts may have been found completely coincidentally because of a scan for another reason. The scan results may be equivocal, they don't quite meet the criteria for making the diagnosis, or the scan results may be unusual. There may be cysts only in one kidney, there may be very few cysts, or there may be a small number of very large cysts, for example. The kidneys may be normal size rather than typically enlarged. Or it may be somebody presenting for the very first time with no family history, so we don't have that family history on which to base our assessment of the likelihood of the diagnosis. Genetic testing has also been offered to individuals who want to know whether they're affected but have not yet undergone a scan. That may be because of their age, for example. That's what we call predictive testing, and there are a number of reasons people might wish to know whether they carry the gene or not. It has been used in some instances in assessing relatives for living-related kidney donation, for example. We are increasingly using it to prepare couples for discussions about what I know has already been mentioned. So that's pre-implantation genetic diagnosis. So that's the genetic screening of embryos generated via IVF techniques. And more increasingly, people are asking us about, well, what does all this information mean to me about the likelihood of developing more significant kidney disease or kidney failure in the future? So-called prognostic or risk scores, which we've already heard mentioned. And also people are asking about, well, if I know my mutation or my family members know the mutation, does that mean it's easier for me to join clinical trials or to join studies looking at what we call the natural history of polycystic kidney disease? So there are many reasons now why we might consider genetic testing. And the first few of those are very, very clearly explained and detailed in the so-called test directory about people seeking testing. So I guess we know that ultrasound scanning is probably the most widely used test for the diagnosis of this condition. But we also know that the features on an ultrasound scan are dependent on the underlying genetic alteration in the family and the age at which the ultrasound scan has been performed. So the younger you are, the fewer cysts you need to make a diagnosis of polycystic kidney disease. The older you are, the more cysts you need. So it is possible at a younger age to have a negative scan, but that does not exclude the development of disease. And this is why genetic testing is also being used in parallel with tests such as an ultrasound scan. So you can see an ultrasound scan is very, very good if you detect this number of cysts in this particular age group. It has what we call a positive predictive value of 100% in all cases. However, it's excluding disease where maybe ultrasound scanning can run into difficulty and where genetic testing may have some value. We know that moving on into using MRI, please don't try and look at all the information in this slide, but we now know if you have an MRI scan or a CT scan, for example, that a threshold of about 10 kidney cysts here is a very, very good indicator at all ages about the confirming a diagnosis of polycystic kidney disease. But still, if you have less than that, there remains uncertainty, and it is therefore possible to use genetic testing for this. And very often we will see families for exactly that point of view. The family history may be very, very clear. We know who's got the condition, and the use of ultrasound, CT or MRI is entirely appropriate. However, people may be seeking the reassurance to know that they don't have this condition if they want to be a donor for a family member, for example. For a young person who may have had a normal ultrasound but wants to know specifically whether or not they've got this condition, and if they don't know whether a parent is affected or not, genetic testing can be used, but there are often lots of issues that need to be explored with the family. For example, it may also be that when a younger individual is considering starting a family from themselves, they want to have this sort of information to be able to base those decisions both now and at some point in the future. And we all know that it's not always in every family that perhaps we're in contact with close family members, for example. So this information isn't always widely available. And the other reason that we're starting to increasingly think about genetic testing is really the sort of information that is important to individuals and family members with polycystic kidney disease. And there are an increasingly large number of surveys coming out, certainly thinking about research studies or clinical trial outcomes, that say to us that kidney function is the most important thing for individuals and families with PKD to try and understand and have more information on kidney function and the development of kidney failure, for example. And that's when we're starting to think about predicting kidney function in polycystic kidney disease. We've already heard about the Pro-PKD score in a previous talk. And this is one of the new scoring systems that have certainly been developed in the research environment that is starting to try and give us the ability to use information about predicting what will happen to kidney function in the future. I do need to say that the Pro-PKD score is one of the scoring systems in development. They've been often generated in the research environment, but they do still require formal validation, and that is starting to happen in the clinical setting in routine clinical use. And a number of centers are doing this. We're also doing this, but it requires the ongoing collection of a lot of information to be able to say that these scores are good and they are accurate. The interesting thing about the Pro-PKD score is that this is not using information about kidney size or kidney volume that you may have heard about. This is using information about very simple information that we would collect in clinic. The difficulty is for this one is that this requires this information to be collected up to the age of 35. So it may not be more relevant for younger individuals, but it's things like, are you male or female? Do you have normal blood pressure or raised blood pressure? Have you had a so-called urological event, pain or bleeding or something like that? And then it builds on the knowledge of the underlying PKD gene genetic alteration. So the type of genetic alteration in the PKD1 gene and whether you have a change in the PKD2 gene. And what that allows us to do is to build up a score. So the maximum score would be 9 and the lowest score 1. And we can split those into sort of 1 to 3, 4 to 6, and 7 to 9. And it tells us that the higher your score, the greater your risk of your kidney function declining at a younger age. As you can see by this particular slope here, it is moved some 20 to 30 years to the left here than this particular line here, which is a low score, 1 to 3. So you can see that you might have a low score if you are female, you are well with normal blood pressure and no symptoms, and you have a PKD2 mutation, whereas you might have a higher score if you have a so-called truncating or loss of function PKD1 mutation, you're male and you have a number of symptoms of polycystic kidney disease occurring at a relatively young age. And this has been used to make predictions, and I have to use the word predictions. This does not tell you with absolute certainty what's going to have, about what might happen in the future to your kidney function. And this is just putting some numbers around that particular graph, where if you're low risk, then perhaps your risk of kidney failure by age 60 is relatively low at about 20%. If you're in the high risk group, your risk of kidney failure at the age of 60 is much higher at about 90%. So you can see that there is potentially some utility or validity or useful information that can be gathered by these scoring systems. But as I've said, they do have to be validated in the real world situation, but already they're starting to be incorporated into decision-making processes about whether people might benefit from certain therapeutic interventions or treatments, such as tolvaptan, for example, and they do exist in guidelines. And there are other studies bearing this out. I'm only putting this up for illustration. The Pro-PKD score was developed in a French cohort of patients. This is information from a Canadian cohort of patients, and it essentially says the same thing, that by looking at the type of genetic alteration, you can split people into so-called slow progressors and patients who are perhaps at higher risk of progression of their disease. And again, they've assigned or been able to look at the averages of sort of ages of development of kidney failure, depending on the type of mutation. And again, you can see here this nearly 30-year difference between the more rapid and the more slower. So we're really trying to work very, very hard to work out what the benefit is of having these scoring systems in the clinic, alongside some of the other predictions that we can make using kidney size, or very simply looking at the changes in your kidney function based on GFR or creatinine levels. They're all currently being evaluated in clinic. But when we look at that, we also have to take into account how variable polycystic kidney disease is within each family. So we all in a family would share the same genetic alteration. Does it mean that those genetic predictions that I've made already in the Pro-PKD score can be applied to each individual family member? Well, the answer with the Pro-PKD score is no, because individual family members may have different features such as blood pressure or symptoms, for example. But we now know, again, this is information from the Canadian study, that when you look within each individual family, so here's an individual family with different family members, that the difference between age of onset of kidney failure, for example, can vary absolutely enormously. So we know that there can be quite marked variability. So we can't always say that what happens to one family member will happen to other family members. So a genetic test has to be interpreted more cautiously than that. And what we know so far is that about 10% of families will show this marked variability, where you can have family members with mild disease and family members with more severe disease. And that occurs across all the different types of genetic alteration in both genes. So we do need to be cautious, and it probably means we have to use genetic scoring systems in the context of other information about individuals and families. I'm getting close to the end now. You'll be delighted to hear. There is no such thing as a virtual sandwich, I'm afraid, which I apologize for, so I feel not uncomfortable about keeping you from your lunch. So the other big question that we are constantly asked, well, should I have genetic testing? And this is why it's very important for the person who's discussing genetic testing with you to have quite a detailed knowledge of its benefits, its pros and its cons. And genetic counselling is an important part of seeking genetic testing. In Cambridge, as in many other genetic centres now, we're very lucky to be able to merge kidney specialist nephrologists with individuals with that level of experience in genetic testing. So the benefits can certainly be confirming a diagnosis, confirming the gene involved. It provides information for individuals and family members. It can be used for donor evaluation, thinking about treatment options, family planning, and also access to research studies. However, we are aware of the fact that this doesn't always work for everybody. It does cause worry and anxiety. It can cause uncertainty. Knowledge of future risks that potentially we can't do anything about now is something that we need to be aware of. Would you want to know at the age of 16 or 18 what your potential future risks are? Some people are not prepared at that age to know that. The uncertainty about the result, we may have to tell you that we found a variant that we don't know. We can't tell you what it means. And of course, in pre-symptomatic testing of learning whether you carry the gene, and you may then go on to develop the condition at a later age. There are always concerns about insurance and careers, and we can talk about that afterwards. There's a lot of information about this via the charity. And obviously the utility. Are we absolutely certain about the benefits of having the test in the clinic? For certain groups of patients, I think we absolutely are, in terms of perhaps making a diagnosis. For example, I think we're fully understanding of that, and also the role of genetic testing in things like PGD. But these are still things that need to be fully explored. And of course, other people have worries about who will see their result. Well, who will see your result? Well, the person who ordered the test, your clinician, for example. The doctors and the scientists who interpret the result in the laboratory before it's reported. And very generally, we would report that result to your GP as well, but not always. And of course, you should always see that result. We still stumble across a few people who've had genetic testing who were not aware of that result. So you should always ask for a copy of your test result, whether that's sent to you electronically through a MyChart or some sort of electronic system that we have, Patient View, for example. And you can share your result with other family members if you want to. You may also be asked to share the result with other family members, in which case you will be asked for your consent to do this. And you may also be asked to join a research study, in which the research study, under tight ethical approvals, will also see your results. So those are the situations where it can be seen, but no one else outside of this has the right to see your result. Insurance people, employers, for example. And of course, one that's cropping up more and more recently, since a number of guidelines were sent out, can I test my children? And remember, this does still remain a very difficult area. We do have guidelines that are providing a framework for doing this. Most commonly, this is requested for diagnostic testing. That will be how I would use this test more often. It's often a child who's been found to have kidney cysts, but the parent scans are normal, so we don't know. Sometimes it's been a child who's found to have kidney cysts and a parent is also known to have it, but it's not clear whether they're affected or not. So there are a number of reasons for doing this. We have to respect a child's autonomy and ability to consent at some point in the future, and it does require expert and professional genetic counselling. It can be considered as well if it will help with screening, if there are symptoms, high blood pressure and so on, and it may well support treatment options. But very typically in children, if there is a family history, we need to know the genetic alteration in another affected adult. We wouldn't really carry out testing just to find out. And we have the option just simply to consider blood pressure monitoring, perhaps with ultrasound scanning, occasionally with monitoring kidney function if there are real concerns. There are options in children. I'm not going to go through the guidelines there on this slide. They are available, but the final guideline does say that if you're thinking about genetic testing or planning it in children or young people, thinking about testing an adult family member first should be considered. And these guidelines have been developed by a lot of professionals in the UK and chaired by Jan Dudley, who's a paediatric nephrologist in Bristol. So we are there. So genetic testing is available via the NHS, and it can be accessed by all kidney specialists and geneticists. It complements but does not replace routine clinical care, including imaging, but I hope I've shown you the benefits in certain areas of adding in genetic testing into your clinical care. It is most typically used to confirm a diagnosis, for predictive testing, and increasingly in donor evaluation, although it does very, very clearly sit alongside careful interpretation of imaging studies. It's got an increasing role in assessing risk of disease progression and potential treatment options that you've already heard about. And families may request testing and are increasingly doing so as part of their decision to start their own family. And again, just to look at very briefly, genetic testing is now starting to be embedded in all the professional disease management guidelines that are being published. So all of our professional colleagues will be aware of this, and you can see that certainly in the sort of these pathways that are now being published from first, second and third visit, that genetic counselling and genetic testing is embedded into these end-to-end care pathways. And there's lots of information about there. I will signpost you to the ADPKD route map. You'll find information about this, I guess, through PKD International and other organizations, the PKD Charity. And there are specific pages here about thinking about genetics and genetic testing. And I would strongly encourage you to use this information if you wanted to think about this in more detail. So thank you very much for listening. I apologize I've gone on a little bit, but Q&A now, if that would be helpful. Thank you.
Thanks, Richard, and thank you for clarifying the definition of autosomal. Despite being diagnosed myself 37 years ago, I've never really quite understood the full meaning. So that was really helpful, and hopefully it was really helpful for everybody else.
Yeah.
There are several. We're going to delay lunch a little bit because there are several questions here. Would you want me to sort of share those with you, or do you want to take a look at them yourself?
Do you want to rattle through a few to start off with?
Okay, super. So, question here about, does the severity of PKD depend upon the number of faulty genes that you have on the chromosome?
To a certain extent, yes. For the majority of individuals, you will carry a single genetic alteration that is significant in either PKD1 or PKD2. We are aware that a smaller number of people will carry a significant genetic alteration in PKD1 and another one in PKD2. That number of families is very, very small. What we are more aware of is that some people, especially with a genetic alteration in PKD1, will carry another alteration in the PKD1 gene that by itself would not be sufficient to cause the condition, but does what we call modify the effect of the other genetic alteration. So these are so-called genetic modifiers, and we have seen people who've got one main genetic alteration that causes the disease and at least one other genetic alteration where the evidence is good that additional genetic alteration in most instances will make the condition perhaps progress at a faster rate. So we would always look for those genetic alterations, but the vast majority of people will get a report which says we have identified a single genetic alteration. There are many, many other genes that cause polycystic kidney disease as part of ciliopathies, and we are just starting to scratch the surface about whether genetic alteration in those genes can contribute to how somebody with ADPKD is affected. But that information is probably going to take quite a long time to come through, as it requires an awful lot of data collection, as I think John Sayer suggested in his talk as well.
Thank you. I think this question possibly ties in a little bit with your last answer, which is, aside from detecting if a person has PKD1 or 2, are there any other genetic indications about how someone's PKD might progress?
Yes, I think the answer to that is the sort of the information that I've given you really focuses on thinking about correlating what is going on with an individual with PKD in terms of changes of kidney function and a single genetic alteration in PKD1 or PKD2. So we're trying to make very tight associations between those pieces of information. What we're not doing at the moment, and what we are all trying to do, is to work out how other bits of genetic information, how your genomics, if you like, how your genetic variation across your whole genome might also contribute to this. And we know it does this for other types of kidney disease. We know that there are other more common genetic alterations that, together with many dozens, hundreds, or maybe thousands of other genetic alterations, can influence how something like chronic kidney disease can develop in the general population. And I think our understanding is that it's likely to be that level of genetic variation in our genetic makeup may also make a small to modest contribution about how the genetic alterations in PKD1 and PKD2 affect our kidney disease. So it's a big, complex process, but we are getting there.
Thanks. So this one is asking about sort of evidence of genetic mutation in eggs. So they're asking whether is there a chance that the PKD or the genetic mutation is not detectable at the egg stage? I think that's essentially what
So that question may relate to the fact that is it possible that if I've got polycystic kidney disease, the genetic alteration won't be present in my eggs, so there won't be the 50-50 chance of having a child with this condition. There is a chance of that, but the likelihood of that is probably going to be very, very low. So this probably relates to a situation that is called mosaicism, where an individual has some cells in their body, presumably definitely in their kidneys, that contain a genetic alteration that causes the polycystic kidney disease, but that genetic alteration is not present in all cells of the body, and that may therefore include egg or sperm. We certainly have seen that in some people in our clinic. That would need to be in an individual who's not got a family history of polycystic kidney disease. And we've seen it more in the context of people who've got a more unusual or atypical presentation of polycystic kidney disease. The most notable one I can think of is somebody who had polycystic kidney disease in one kidney and not the other. And that was a very clear indication that they were likely to be mosaic. And indeed, they went on and had 6 children, none of whom had polycystic kidney disease. But that would be the best way of testing that. We can sometimes get evidence of mosaicism on a blood test. On a blood test, we would normally expect to see half of the copies of your gene having the genetic alteration and the other half not. Sometimes that 50-50 ratio is altered, and that can be an indication of that. But most of the time when we're carrying out our genetic counselling, we would assume that there is a 50-50 risk for children in the future. And that's where discussions around things like PGD come in.
But can you confirm what PDG is?
Oh, sorry, this is going back to pre-implantation genetic diagnosis. So I'm aware that this can be quite a tricky conversation for individuals and families, and also their kidney specialists. It's very routine in our own clinic. And I will point out that, you know, in the context of our kidney clinic, for the 30 years I've been doing it, I've never been involved in what I call prenatal diagnosis, which is testing a pregnancy and then maybe deciding on the basis of a genetic test result not to continue with the pregnancy. But I do know it does happen. But more people are now becoming more interested in pre-implantation genetic diagnosis. So that's having IVF and then testing embryos before they're used to establish a pregnancy, and only using embryos that do not carry an unaltered copy of a PKD gene. So that's pre-implantation genetic diagnosis, often called PGD. And I'm pretty certain there's something on the PKD Charity website about this. If there isn't, Tess, I'm sure you'll put me right.
There is.
There is. Thank you. I hope that makes sense.
About, spontaneous mutation. And I noticed it throughout the morning. This is cropped up. So can you talk to us a little bit more about, you know, how that works? You know, where there's no existing family history, somebody presents with PKD.
So about 1 in 10 individuals, on the basis of really big comprehensive studies now, will have what's called a new mutation or a de novo mutation in one of their PKD genes. And that's based on there being no family history, even after extensive screening, typically of parents, but maybe other family members. And that's the basis on where the 10% figure comes from. If you just look at somebody in clinic who comes to clinic and says, I've got no family history, then that figure increases to about 1/3, and that's our experience. But that's simply because close relatives or parents have not been screened or tested or are not available for testing. So when it's done thoroughly, it's about 1 in 10 people. They represent the first member of their family with this condition. And the likelihood of that is simply because the genetic alteration arose at a very, very, very early time following conception. We don't know why it occurs. There is something to do with the complexity of the PKD1 gene that makes it more likely that these errors occur, but why they occur, we don't know. Genetic alterations occur all the time as normal, healthy individuals. If you look at our entire genetic makeup, you will find a significant number of new genetic alterations occurring all the time. So it's probably simply due to the fact that the body's systems of copying that enormous amount of genetic information every time a cell divides into a new cell it's pretty darn good, but it's not always perfect. And if that alteration occurs in a medically important gene, that's when the disease arrives. So that's probably the explanation for the majority of people who appear to represent the first case in their family. But as the first case, there would still, for them, most likely be the 50-50 risk of passing it on in the future.
Thank you. This is a really interesting question. Why do cysts develop on other organs if the problem exists within the kidneys, if the primary problem exists within the kidneys?
Yeah, so for the vast majority of us, the inherited change in the PKD1 gene the PKD1 gene works or is expressed in virtually every cell of our bodies. So in a sense, with an altered copy of the gene and a normal copy of the gene, every tissue is potentially at risk of developing some sort of complication. However, it's much more likely that we will only see features of the disease in tissues where the PKD1 gene products, the polycystins, have a key or functional role. And it seems that those are most likely in the kidney, the liver, the pancreas, where we get pancreatic cysts, and elsewhere. In other tissues, having an altered copy just doesn't seem to be important enough for it to cause a particular medical problem. People have also thought that carrying a mutation in the cells of your blood vessels also may cause some consequence, such as raised blood pressure or an aneurysm, for example. We are also aware that in most of our cells, we have one altered copy and a second normal copy. What appears to be the case in the kidney and liver, the second copy of the gene somehow becomes altered in a cell. That's the so-called second hit. And that seems to be most likely to occur in tissues such as the kidney and liver. So that's probably why we see it in tissues outside of the kidney. It's where the gene function is also important, and also where there's a slightly higher risk of developing this so-called second hit. But we often don't have an explanation for a lot of genetic conditions about why we don't see features elsewhere.
Thanks. Another question that's appeared today, and also we see regularly, within the sort of the community, is the sort of confirming the point in which clinicians can confirm a positive or a negative diagnosis. Sort of around the age.
Yeah.
We'll talk a little bit about that.
Are we thinking about sort of imaging here, or with?
I'm talking about. Yeah, I'm talking about. Well, either. I think.
Yeah.
Yeah.
No, I think that's important, and I think it's very important when you're thinking about that genetically. Obviously, as a parent, we pass on 50% of our genetic makeup. So when we have a genetic test, in a sense, we're testing 50% of our children's genetic makeup as well. And I think that's always very important to consider. But a DNA test can be carried out at any age or any time. So the result will be the same, whatever age you do the genetic test. So you, in theory, can make a diagnosis at any age using genetic testing. Imaging is relevant to a particular point in time. So we know that for ultrasound scanning, for example, there's very good evidence to suggest that for the majority of individuals beyond the age of about 15, for example, that will have quite a high specificity. It will make a diagnosis if cysts are there, but relatively low sensitivity. So it's potentially will miss individuals who haven't yet developed cysts. And really, that information only becomes much more certain once people start to reach the age of about 30, but in milder types of polycystic kidney disease, perhaps associated with alterations in the PKD2 gene, up to the age of about 40. But however, the utility of an ultrasound, a CT or an MRI is certainly pretty good, even in late teens, early 20s. But to get that absolute level of certainty, sometimes scanning has to carry on until an older age, but it's usually that age range. And that's where genetic testing can complement imaging to give somebody potentially at a younger age with a normal scan, or perhaps only a few kidney cysts, the certainty of knowing whether they have the condition or not.
Okay, thank you. I'm very, very conscious of time, and that we've probably very, very hungry people out there.
Sorry.
Have you got any more questions? Or should we go straight into lunch? Okay, yeah, no, sorry, Richard, thank you.
No, not at all.
I think we probably need to get people need to be fed.
Yeah.
We could have a riot on our hands. But hopefully that's been really helpful for you all. Thank you very much. And we're now going to have lunch. You don't need to leave the webinar. People that have joined us, you can leave it open, and then we'll see you again at 2:30.
Brilliant. Okay, thanks very much. Bye-bye.
Thank you very much. Thanks, Richard. Bye-bye.